In this lecture, I'm going to be talking about the development of new specializations in healthcare that resulted from the larger hospice and palliative care movement. And again, this is a vast topic, so I'm just going to be highlighting some specific examples that I have information on. And unsurprisingly, this really happens first in the UK, where the first hospice was built. And so they had a longer history of having that successful hospice and the driving force of Cicely Saunders there and all of her allies. And so that became the first place where hospice palliative care is first recognized as a subdiscipline of medicine itself. And so in his book, To Comfort Always, David Clark talks about the larger history of medicine in that book and how it struggles with dealing with this new approach. And so he talks about the earlier unification of medicine and surgery, and then in the 20th century, the increasing specialization of medicine. Now, when I have another hat on and I'm teaching another course, I'm actually somewhat critical of this particular trend in medicine towards these constant subspecializations. I think in some cases, it's led to an extremely fragmented medical system, in my opinion, where people are just being sent out to all these different specialists and there's no one person that's kind of, I just know this from my own experience in my own family. But in this case, specialization actually worked in the favor of palliative care. And so it makes it possible to slot this into the system in a way that works quite effectively. So this is an example of where specialization actually works very effectively. And so it was officially recognized in the UK in 1987 as a subspecialty of medicine. And so it had to be defined. Obviously, if you're going to start saying this is a subspecialty, it has to be defined as an activity recognized by the wider healthcare system. So you can see how far this came in a relatively short period of time, where we see in the 1960s doctors often not even telling people they're terminal, for instance. And so by 1987, this is a complete sea change, and we see that the parameters of palliative care, these are constantly being mediated over time and in different places of what we mean by palliative care. So just for instance, in the Ontario case, I'm going to be talking about a document that was put out by the RNAO, the Registered Nursing Association of Ontario, that's talking about palliative care as 12 months prior. So certainly in Canada, palliative care in the beginning would have been thinking like we're talking about in weeks, but we're seeing that it's now coming to encompass longer periods of time. So there's no definitive statement on this. But by 1987 in the UK, they had established at least some parameters of the field. And this has actual concrete consequences, of course, which include education. And so that's where all of you and I come in. I consider myself part of this larger endeavor of if we're going to bring in this new specialization, that's going to include different forms of education. And in my opinion, particularly in this specialization, I personally believe that all people in healthcare should be doing courses on death and dying and history of religion and so on. But certainly in palliative care, I think I hope there's not too much argument about that. Maybe there is, I don't know. So education becomes a very important component, obviously. Training becomes an important component, and then research. And all of these things have effloresced. And so we're seeing all of it in the present, as is happening in the UK and all around the world. So as I said, it was recognized by the medical establishment in the UK as a legitimate field of medicine and a specialization. And so it gets the imprimatur of the larger system. And so St. Christopher's, unsurprisingly, is playing a really important role here. And if you recall, I talked about the way that Saunders very specifically set it up as what is referred to as a center of excellence, which means there's clinical care going on, but it's also a place for teaching and research. So she saw that right from the beginning, that those elements would be important in palliative care, and also that she set it up as an example. And so in the UK, they were able to look at that, and around the world. So we also see all the hallmarks of something being accepted by the establishment, which is a growing cadres of doctors starting to train in that field, often working at hospices in UK and getting their training there. And then there are also activists in the field pushing this forward. And so three of the main people in the UK were Derek Doyle, Robert Twycross, and Richard Hillier, who were close associates of Cicely Saunders, who became among the first doctors to start really developing this whole idea. And so a journal was founded around the same time. And so again, in the field of medicine, the idea of having a separate journal is another hallmark of acceptance by the mainstream. We also start to see the development of chairs of research in universities, and so the full complement is there at that point. And so there was a chair appointed in London for the study of palliative care, and so the person in the chair is the one pushing forward whole fields of research. And so this has been an ongoing process. And so we also see a chair of palliative care at McGill University in Canada. And so this is increasingly becoming common. So all of these elements, the training at the medical clinical level, the education, the curriculum, and the research aspect. I want to turn now to looking at palliative care physicians, and if any of you have known any, I've met a few. They're a very different breed, and I like to use the example of an ER, an emergency room doctor or nurse versus a palliative care physician or nurse. That to me shows very clearly the distinction in approach. And so in my experience with palliative care physicians, they have a very different kind of vibration about them. So they're not, obviously, this is for a reason. If you're in an emergency room, you're trying to save lives. It's acute care, that's what you're doing. Whereas for palliative care, it's a very, very different ecosystem you're working within. And so the physicians or nurses are obviously having to work very closely with families in this case, and if it's a death that's taking a period of time, those are relationships over time. So it's a completely different approach that has to happen. And so it makes sense that they have to get a very specific kind of training. And this is, in my opinion, and in the opinion of a number of different people in the field, where we're seeing that we have to push back against what's been called creeping medicalization, where the technical aspects start to overpower that holistic approach that was right there at the beginning. And even if we look at that idea of total pain and looking at the dimensions of suffering. So if we allow for that creeping medicalization, it's just going to become another version of that highly technical approach. And so this is an ongoing challenge, and I think this is where the curriculum piece comes in. So, so when we look at palliative care physicians, the image here is of Dr. Nadia Tremonti, who is a palliative care physician who works in pediatric palliative care in Michigan. And I will be attaching a documentary on her to this section of the course. And I'm warning you, I just described what this documentary was about to a friend and she started weeping. So this is as heavy as it gets and as important as it gets, the work that she's doing. And I think she's such an example of what it looks like to be a palliative care physician. And so I just wanted to share a quote from Dr. Rachel Naomi Raymond, who writes the introduction to a book called Making Healthcare Whole. So we're seeing this is not just coming from academics or religious people, this concern with curriculum. So we're seeing that doctors and nurses themselves are very concerned that the field, as it becomes more and more mainstream, that it doesn't lose kind of this what makes it different. And so the subtitle of this book is called Integrating Spirituality into Patient Care. And so so she writes on page 15, As health professionals, we often meet people at the thresholds of the world, welcoming them when they are born and letting go of their hands as they die. Yet little in our training prepares us to have comfort with the unknown, or even to recognize the spiritual nature of such meetings. And to me, that's at the heart of it, and it's at the heart of why I created this course in the first place. That obviously, when people when they're working in medicine, they are not necessarily trained in how to deal with these situations. And so palliative care, in a certain way, is a kind of a vanguard in this way of engaging with this right from the beginning and integrating it into training. And so palliative care training looks different in different regions, and as many of you will know, in Canada, the provinces have control of healthcare. So I'm looking more specifically at Ontario throughout this section. But we see an increasing ability to train in palliative care for physicians, and so there is a Canadian Palliative Care Association, Canadian Society of Palliative Medicine, and also one for nurses that I'll be talking about shortly. And I looked up, there's training opportunities that are online. So University of BC, University of Calgary, University of Alberta, and on and on. And so we're seeing residency programs that are available, and it makes sense. And this is true for all of medicine, but obviously on the ground training is often the best. You need the book learning, but you need to have that on the ground training. So that's becoming increasingly available as there's more hospices and there's more training programs. I want to turn now to palliative care nursing, and again, this is a vast topic, so I'm going to be focusing on the case of Ontario and just highlighting some important aspects of the training, but I don't want to focus too much on the nuts and bolts, because in a sense then I'm giving into that creeping medicalization, and I don't think that's my role. And so I came across, there's not a lot written on the history of palliative care nursing, actually, and in Clark's book he doesn't even mention it in the section that I was reading from. So I came across a thesis done by somebody at the University of Alberta. I will attach it to Blackboard. I obviously don't expect you to read the whole thesis unless you want to. It's over 200 pages, but I just want you to look at the introduction to that thesis. And so the title says a lot. It's from 2002, but she writes, so Donna Riffin, who wrote it, writes, Accompanying the Dying. That's the title of the thesis. Nurses create a moral space for suffering. So we can see right from the title, this is not about the medical, clinical aspects of the care, which are obviously extremely important, but she's addressing herself to these other humanistic elements of care. And so she talks about the idea of the moral obligation to suffer with others. So that's right at the center of how she's understanding palliative care nursing, and in what I have read about, certainly when it's written by an actual nurse, that's often the kind of language that they're using. So you can see we've stepped out of the realm of science and technology here. We're in the humanistic realm. And so the moral obligation to suffer with others. So when we're using that kind of language, you can see we're going right back to the beginning antecedents of hospice that we looked at in the very beginning of the course. And so she argues that this has always been integral. So part of what makes hospice and palliative care so different and so important is that it combines the science and technology and the knowledge of the psychosocial nature of care with this element, this humanistic element, this moral, ethical, spiritual element. And she notes also the self-knowledge of the nurse. So all of these elements. So she talks about the fact that this is, I assume, true of any nurse, but it's an intimate relationship, and it's particularly intimate when you're working with somebody who's in the last days of their life. And so she refers to it as a moral relationship, and the need for this to be included within the training of nurses. So at the end, she gives some suggestions. I invite you to look at that if that's something you're interested or that's relevant to you. So she talks about the difference between healing versus curing, and I talk about this in my health and healing course, that the idea that these are not synonyms. So curing is much more what they're doing in a sort of a mainstream hospital, but healing is much more about that larger person, the holistic version of a person. And so she talks about the idea of volunteering at hospice could be a good way for somebody to become comfortable with this, and or if they want to start training in palliative care nursing. And so we've seen the creation of a number of different associations to do with palliative care, and it has now become a subspecialty also within nursing. So this is a moving target as the field develops. And so we see the creation of the Canadian Palliative Care Nursing Association. And as with all these associations, this becomes a kind of clearinghouse so that if people are interested in this topic, they can learn how to be trained. And so from what I have seen, this body, and this is how it works in Ontario, I don't know how it works in other places in the world, but the idea that these overarching bodies for the disciplines of nursing or medicine sort of create the parameters that then have to be followed. So this group has created the parameters for getting certified in palliative care. I suspect some of you may have gone through this. So if you have, I really invite you to share that with the rest of the class. And so I came across a document from 2020, and so it is from the Registered Nurses Association of Ontario, a palliative approach to care in the last 12 months of life. So I will be attaching this to this section of the course. And again, it's a fairly long document, but it was put together by a whole panel of experts in the field, and then it makes recommendations. So I do want to look at that just in the last part of the lecture here. And so it says, recommendation 1, the expert panel recommends that health service organizations implement an interprofessional model of care for the provision of palliative care and end-of-life care to persons and families. So as I mentioned already, we can see the idea that this team model is very much what's being recommended. I mean, this is something that happens somewhat organically in the history of palliative care, but it seems there's the need to make this a set kind of characteristic of palliative care. And as I said, extending the length of time, and this is also again related to the fact that of the aging population. So you can see this working hand in hand with how the government and other groups are trying to handle the fact that we have this a rapidly aging population. And so so recommendation 2, the expert panel recommends that the interprofessional health team, in collaboration with the person and family, develop an individualized, person-centered plan of care and reevaluate the plan of care based on the changing status, needs, and preferences of the person. So 2 very important things here, that idea of the importance of the family and the community around the person and using that as a resource. It's often been the case in history that people in medicine, in my experience, see the family and friends as kind of a nuisance. So this is the exact opposite, which is leveraging the help and care of those people into the plan of care. And I know this is happening now, but certainly 20, 30 years ago, it wasn't a central idea. And again, this concept of person-centered care. And this is where I think hospice and palliative care has been really leading the charge here. And I'll talk about it when we're at the conclusion of the course, of the impacts that I think that hospice and palliative care are increasingly having on the healthcare sector more generally. And so this idea of putting the person back at the center of care, unfortunately, partly as a result of that creepy medicalization, we've seen it shifting where it becomes about the technology the sort of the demands of the technology and the kind of bureaucracy of care rather than the person. And so this is a real pushback that we're seeing from nurses in palliative care to say we need to put human beings and their families back at the center of it. And then to the subject of this course, what nurse-led interventions should be recommended for a palliative approach to the delivery of care in the last 12 months of life? Outcomes: support for spiritual care, support for emotional care, support for existential care, care in alignment with the person's wishes, culturally safe care, place of death. Okay, so we can see that this panel is recognizing also that this can get lost, the idea of the spiritual, emotional aspects of care for both the person and their family. And so also the idea of culturally competent, culturally safe care. And so this obviously is a recognition that in Canada, people are coming from a variety of backgrounds. A variety of religions. They could be atheists. They could be of any religious background. They could be agnostic. So recognizing the need to understand that. And I would add into this that be available also for the nurses. And in the dissertation that I was talking about and that I'll be attaching to this section, Riffin also talks about that. Now, that's not to say that all nurses or doctors have a religious or spiritual belief. Some of them don't. But I think it's very important, and this is part of the work that I do, of at least making that available as a resource, as a possible resource, both for the patient, the family, and the caregivers. Because as you're going to see in that documentary, the things that are being asked of the physician and the nurse are just so huge that even if it's not religious, they will need their own resources to bring to the table to be able to do that work. And this is something I've noticed that's true. I mean, it's true for all human beings, obviously, but certainly people who work in the caring professions where so much energy is going out to others, this becomes particularly true. So I just wanted to conclude by, again, looking at the foreword by Rachel Naomi Raymond in Making Healthcare Whole. So she writes, as health professionals, our relationship with the spiritual dimension of life is intimate, but often unaware. This became clear to me some years ago when I was part of a seminar Joseph Campbell ran for physicians on the experience of spiritual reality. And so I find this really, really interesting, and you'll see in the documentary that there's a part where Dr. Tremonti is giving a lecture to a small group of palliative care trainees about how to handle and how to work with families, and you can see the terror on the face of these young doctors learning this and how challenging this is. And so basically this idea that when you're working with people who are close to death, these elements are going to come in, and often people are not aware of them. So it's in this intimate journey, as Riffin talks about it. So the doctors who had gathered together were uncomfortable with the topic, uncertain of what spiritual reality had to do with us and with our work. Recognizing this, Campbell opened the session by projecting images of sacred art on the screen before us, painting and sculptures and tapestries. One of these works remains clear in my memory, a small bronze of a dancing Shiva, the god of creation, so from the Hindu tradition, from a museum in Europe. I remember being struck by the beauty and joy of the little figure, dancing with abandon in a ring of bronze flame, one foot lifted high in the air, and the other resting on the back of a little man crouched in the dust, completely absorbed in something that he was holding between his hands. Looking more closely, I could see that the focus of his attention was a leaf. Others, too, were struck by the beauty of the figure, but we were all trained observers and posers of questions, and so one of us spoke up and asked Campbell, what is the little man doing there? Aha, Campbell explained, that little man is someone who is so caught up in the study of the material world that he does not know that the living God is dancing on his back. There was a long silence, and Campbell looked at us sitting there in our white coats, suits and ties, and smiled. So she goes on to say, "There's little in our highly technological training that encourages us to recognize or respond to spiritual reality. Yet the spirit is part of our daily lives and health professions. Our medical culture often limits the way that we think, the ways that we see things. It interprets our experience for us in ways that are often constricted and small." So as I said at the beginning, more and more people, doctors, nurses, social workers, other people in the professions around medicine, are recognizing the issue at hand, which is the need to engage in these dimensions. And so I just wanted to end with a poem that Raymond includes in this introduction. So she says, "Years ago, a man with terminal cancer who came to one of the Commonwealth's cancer retreats pressed a poem into my hand as he left. He had crafted it from words of others because it spoke to his experience of mystery and healing at the end of life." And Raymond's very clear in this introduction that once we're dealing with death and dying, we're entering into a realm of mystery and a place where there's no such thing as mastery. And so certainly, and this is true in academics, this is true of many, many fields, this idea that we're often taught that we want to be in control and we want to feel a sense of mastery. And so the minute we're talking about death and dying, we move into a field that is essentially mysterious, however we understand that. So it spoke to his experience of mystery and healing at the end of life. So again, that idea of healing at the end of life, there's no such thing as curing at the end of life, but that there's a larger dimension of healing. And the relationship he hoped to find with the professionals who accompanied him there and cared for him. So I find this very beautiful, this idea that he's written this poem that he's giving to his physician to express how he's feeling. And so I'm just going to end with the poem here, and there's definitely some elements of the Sufi poet Rumi here. "I had a dream that honeybees were making honey in my heart out of my old failures. There is no right or wrong. Beyond the wrong and right, there is a field. I'll meet you there."